We have a separate retina division in terms of overseeing the retinal practices, because really they do encompass, as just one subspecialty, they encompass a tremendous amount. So if I look at retina, I think all areas of ophthalmology are going to be benefiting as all of the baby boomers out there live longer and longer. Well, there's a reason that we call macular degeneration age-related macular degeneration. It's called ARMD, which is already tremendously relevant in terms of demographic, but will become increasingly so. There's just a tremendous amount of experience, decades worth, with, again, I'll use New England Retina. In terms of other retina practices that are thinking of coming on board, there's the ability to have a lot of, let's say, soundboarding in terms of difficult cases, management, and so that certainly exists. So I think that's really an important part of why there's an appeal, or I think there should be an appeal in terms of practices that currently may be retina practices.
With ReFocus now being a very large entity in the upper Northeast and the Mid-Atlantic area, we're lucky enough to sort of have this fusion of some great mindsets, some subject matter experts in retina, in interventional glaucoma, in ocular surface, in optometry, in ophthalmology. It's really great to have that library of physicians as we continue to grow together to really reach out to and to really help you in the pickle you may be in, or if you want to innovate. So I've gotten numerous calls from doctors, not only within our consortium, but outside, say, Jay, I heard you give a talk. I heard you're doing this in your practice. How can I do it better in my practice? So that's shared, and it doesn't just go one way. It's for me too. That symbiosis has been incredibly important. And ReFocus, by the way, fosters that. We're going to be doing something special the next couple of months, looking at how we can improve the conversion rate in cataract surgery towards doing upgrades for our patients, or interventional glaucoma, or drop therapy is just a mundane way of taking care of patients. Are there ways to be interventional glaucoma and to offer our patients more lasers or drug delivery or MIGS during the time of their cataract surgery, or as a standalone? Again, having such a great consortium of physicians, ophthalmology and optometry is very, very woven, and it's sort of a tight community. We feel an extra tightness, a family here at ReFocus. As Chief Innovation Officer for ReFocus Eye, I'm thrilled that we have a great cadre of practices up and down the East Coast that are already doing some of the things that we all aspire. How do we get every practice to get better, right? There's no mandate. What may work in my practice may not work in a practice in Southern New Jersey, or in Upper Connecticut, or in Rhode Island, or Massachusetts, or Virginia. Same vice versa. So how do we have everyone look in the mirror as a practice? You know what? How do I get better, for example, in interventional glaucoma? How do I get away from eye drops where compliance is an issue and ocular surface is an issue? And how do I get better in taking care of those patients? Or on the ocular surface, how do I get better and maybe performing or offering IPL or LipiFlow or punctal or lacrimal occlusion or amniotic grafts to help restore the ocular surface? How do I get better in cataract surgery? Do I just do what's the base that insurance pays for and do good cataract surgery? Or do I offer innovative ways to help patients get spectacle free? It may not be femto, it could be LAL, it could be limbal relaxing incisions, it could be the use of toric lenses or monofocal plus lenses, right? This is all part of the innovative cascade in eye care. And whether you go to the bigger optometry meetings or the big ophthalmology meetings or the regional ones or the local ones, you see innovation really being 60-70% of what we're hearing. And on the retina side, how we get better at affording the best outcomes for our patients, such that they may not need to come visit us every couple of weeks and get an injection, which may or may not work, right? We're getting better as a community, as an industry, in affording our patients the best in injection therapy to really maybe delay and lag the time they've got to be seen. And then imaging techniques, right? We have great imaging techniques now, OCT guided techniques in the retina, as well as for glaucoma and the cornea. A great time in eye care.